Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach for Step 1 and Step 2. And today we'll be reviewing a Step 2 CK cardiology question. So let's get started and I'd like you to try to work through this question on your own first. So pay attention as the question runs over a few different slides. A 76-year-old man presents to the emergency department with sudden onset of palpitations and shortness of breath. He has a history of coronary artery disease, previous myocardial infarction 6 months ago, hypertension, and congestive heart failure. His medications include aspirin, atorvastatin, lisinopril, and metoprolol. He is afebrile, heart rate is 150, respiratory rate is 20, and blood pressure is 146/82. He appears anxious and uncomfortable. He is alert and oriented to person, place, and time. Cardiovascular examination reveals normal S1 and S2. Neck veins are not distended and no murmurs are auscultated. Extremities are warm and well perfused and radial pulses are 2+ bilaterally. Breath sounds are clear to auscultation bilaterally and respirations are mildly labored. EKG is performed and is shown here. So take a few moments to look at this EKG. And now let's move on to the next part of the question. Shortly after completing the EKG, the patient starts complaining of chest pain and dizziness. Vital signs are repeated and demonstrate heart rate of 180, respiratory rate of 22, and blood pressure of 76/42. You palpate a tachycardic radial pulse. What is the next best step in management? So take a stab at this question on your own before we work through it together. All right, so welcome back. So let's approach this question together. As always, the first step is going to be to read the actual question itself, so the very last sentence. What is the best next step in management? So this is going to be a management question, and then we glance at the answer choices and we see a number of medications. Some of these look like antiarrhythmics, as well as maybe some cardioversions. So these all look like interventions that are common in arrhythmia questions. And that's pretty much all we need to do. We don't need to spend a lot more time. We just glance at them and we see that what our options are going to be. So then we go back to the start and let's read together and highlight the key elements. A 76-year-old man presents to the emergency department with sudden onset, palpitations, and shortness of breath. He has a history of coronary artery disease, previous myocardial infarction, hypertension, and congestive heart failure. His medications include aspirin, atorvastatin, lisinopril, and metoprolol. It's always really important to highlight the medications that the patients are on as well as their past medical history because often we get into a pattern of just glancing over these quickly, but often the past medical history and the medications are a really important part of the STEM. And oftentimes they might be going after side effects of these medications or some association with the comorbidities. So really important to pay attention to these things. He is afebrile, heart rate is 150, respiratory rate is 20, and blood pressure is 146/82. Also, really important to highlight the abnormal vital signs. They're often going to be important pertinent positives or pertinent negatives. So here the heart rate is 150, so the patient is tachycardic. Respiratory rate is 20, he's a little tachypnic, and blood pressure is on the upper end of normal, 146/82. He appears anxious and uncomfortable. He's alert and oriented to person, place, and time. Cardiovascular examination reveals normal S1 and S2. Neck veins are not distended and no murmurs are auscultated. Extremities are warm and well perfused and radial pulses are 2+ bilaterally. Breath sounds are clear to auscultation and respirations are mildly labored. So overall, pretty benign physical examination, just some mild tachypnea and labored breathing. But overall, nothing too remarkable on the physical examination besides the vital signs. So then let's take a look at this EKG. We'll use a different color here. So when we approach an EKG, big picture, there are a few basic steps that we always need to take. The first step is going to be to look at the rate. Quick tip for looking at the rate is going to be to take two RRs that are falling at around the solid lines here. And you count the number of boxes between the RRs. So in our case, let's take one that fits pretty easily. We can look at, for example, these two. So this RR here, or between two QRS complexes, should I say, falls about 1.5, almost 2 big boxes in between these two complexes. So we take 300 and we divide by the number of boxes, and that's our approximate rate. So we'll say it's about 150. Might be a little bit faster since it's a little bit under 2 full boxes, but for the purposes of this question, this is sufficient. So we always start with the rate. First step, when we use this trick, counting the number of boxes, big boxes between two RRs or two QRS complexes, and we divide 300 by the number of boxes. Then we want to take a look at the rhythm. Is it regular? Is it irregular? Does it look like sinus rhythm? So the things we're looking for here, is there a P wave before every QRS? Does the morphology of the P waves look normal? Does the morphology of the QRS look normal? And is the interval between the QRS complexes regular? So the intervals look fairly regular, but we're not really seeing a P wave before every QRS. In fact, we're barely seeing any P waves at all. We might be seeing a few interspersed here and there, for example, here or here, but generally there's not a P wave before every QRS, so we're not in sinus rhythm. But I would say that this is relatively regular. It's not looking like AFib, for example, where we're seeing very irregular intervals between the QRS complexes. So then we look at the rhythm, and then finally we look at the intervals. And since there aren't really P waves here, the PR interval is less relevant, but the QRS duration is relevant here because, as we can see, the QRS is wide in this case. Remember that the upper limit of normal for a QRS is 120 milliseconds, or 3 little boxes. So we're seeing that the QRS here is wide. So we can take any number of these QRS complexes and we're seeing that it's certainly more than 3 little boxes, even without being able to see the fine details of the little lines. We can just eyeball it and we see that this is a wide complex QRS, and we are not in sinus rhythm. So our interpretation of this EKG big picture would be that this is a wide complex tachycardia. It's not sinus rhythm, and we're not really seeing P waves here. And if we look at the morphology of the QRS, it appears to be relatively monomorphic. Most of these QRS complexes have pretty much the same morphology. So we have a monomorphic wide complex tachycardia, and so this is most consistent with ventricular tachycardia. So when you look at EKGs on the boards, first of all, don't worry about having some very foreign EKG that pops up that you've never seen before. For step 1 and step 2, the only EKGs that you'd be expected to interpret would be for very common rhythms that you should have learned about in med school that you should be able to recognize. Most of them come from the ACLS algorithms, and one of the more common ones that you'll have to recognize is a wide complex tachycardia, a monomorphic one, as well as polymorphic. This will be discussed in a different question, but a wide complex monomorphic tachycardia is most consistent with ventricular tachycardia. So you should be able to recognize this rhythm without being able to necessarily interpret every single EKG you're looking at, but this is one of the most common ones that will pop up on the boards, and is also really important to be able to recognize in terms of your ACLS certification at the end of medical school. So let's move on to the next part of the question. Shortly after completing the EKG, the patient starts complaining of chest pain and dizziness. Vital signs are repeated and demonstrate heart rate of 180, respiratory rate of 22, and blood pressure is 76/42. So now we have a change in the patient's clinical status, going from relatively stable vital signs. The patient was tachycardic and very slightly tachypnic, but the blood pressure was normal, if not at the upper end of normal. And now this is a change in the patient's clinical status, and he develops new chest pain, new dizziness, and now the heart rate is higher, the respiratory rate is about the same, and the blood pressure is all of a sudden quite low. So we're dealing with a previously stable patient in VTAC who is now demonstrating signs of instability as evidenced by this hypotension. And so the question is really asking you, how do we manage unstable ventricular tachycardia? And the key differentiating point here in terms of the management strategies is that it really depends on the presence of a pulse. If the patient has a pulse, it's going to be one certain treatment. If the patient doesn't have a pulse, it's going to be a different treatment. So they tell you, you palpate a tachycardic radial pulse. So in this situation, we are in unstable VTAC with a pulse. And so this takes us down a very specific algorithm in our ACLS algorithms. And you may remember the treatment for this. If you don't take a moment, try to remember on your own. All right, so what did you come up with? So the correct answer here for the management of unstable VTAC with a pulse is going to be synchronized cardioversion. So answer choice G, synchronized cardioversion, is the correct answer. So let's take a look at the other answer choices and see what they're trying to get at here, because all these antiarrhythmics can be very confusing. And so they're often here to trick you because you have heard of these antiarrhythmics being used in these different arrhythmias, but you can't quite remember or pin down exactly what they were used for. And so all these answer choices sound pretty good. So let's go through them together. So adenosine, answer choice A. So this sounds familiar, especially in the setting of tachycardia, but this is the correct answer for SVT that is stable. So stable SVT, you would use adenosine. So this is incorrect. Answer choice B, amiodarone. So this is really close to being correct. Amiodarone would be the correct answer if this was stable VTAC. So this would be the first line antiarrhythmic for stable VTAC. But now this patient's hypotension demonstrates to us that he is no longer stable. He's gone from a blood pressure of 140s over 80s to 70s over 40s. So that's a huge drop in his blood pressure. And so this newfound hypotension associated with chest pain and dizziness are signs of clinical instability. So amiodarone would have been correct before this happened, but once this occurs, it's no longer correct. So it's not amiodarone. Procainamide. So there's another antiarrhythmic that sounds like it could be right. Well, procainamide might be a good option as a second line agent after amiodarone if amiodarone doesn't work, but it's never going to be first line for VTAC, and it's certainly not going to be first line in unstable VTAC. So it's going to be a second line agent for stable VTAC. It's never going to be the right answer unless they've already told you that they've tried amiodarone. Ibutylide. So here's another antiarrhythmic. So this is typically used in AFib to cardiovert someone pharmacologically out of AFib, but it doesn't play a role in VTAC. Magnesium. So magnesium is what's used for torsade de pointe. So this is a polymorphic VTAC, but it's not used in the setting of monomorphic VTAC. So this is for torsade. Epinephrine. So epinephrine is used in ACLS algorithms, but it's used for the cardiac arrest algorithm. So we're not quite there, although certainly this patient could decompensate quickly and go into cardiac arrest. And if that was the case, then epinephrine would be the right answer. But he still has a pulse and his other vital signs, his heart rate is increasing, but his blood pressure is low, but he's still not quite there yet. So this wouldn't be correct. But this would be used if the patient went into cardiac arrest. And then lastly, answer choices G and H. So here you really have to pay attention to whether you want synchronized or unsynchronized cardioversion. So unsynchronized cardioversion is also referred to as defibrillation. So be careful not to get confused. If you're looking for defibrillation in the answer choices and it's not there, you should also be looking for unsynchronized cardioversion. So the difference here really depends on the presence of the pulse. So if the patient still has a pulse, the answer choice is going to be synchronized cardioversion. Once this patient loses his pulse, which he may in the coming minutes, if this question stem were to continue, or if this was a two-part question, for example, or if you see a similar scenario where the patient loses a pulse, in this case, you would use unsynchronized cardioversion. So this is why it's so important to pay attention to the presence of pulses in unstable VTAC. So this is going to be called the correct answer for pulseless VTAC. And this takes us down a different ACLS algorithm. So the correct answer was G, and we examined what these other answer choices could have been correct for and why they weren't appropriate here. So now let's take a moment to review very briefly some high yield information about VTAC. So the risk factors for VTAC are going to be any patient with pre-existing structural heart disease, especially coronary artery disease and a prior myocardial infarction, right? So our patient in the stem, we'll go back to the stem to point out a few additional elements in the history, but our patient had a history of structural heart disease. So that was a major clue that this wide complex tachycardia we were dealing with was VTAC. It's going to present like any other arrhythmia with palpitations, dyspnea, maybe some chest discomfort, can even progress to chest pain, syncope or presyncope, or even cardiac arrest. So there's a wide spectrum of presentations, anywhere from mild symptoms like maybe palpitations and dyspnea all the way to cardiac arrest. The EKG features are going to be a monomorphic, so that means that the QRS looks pretty much the same. All the QRS complexes look very similar. Wide complex, so greater than 120 milliseconds tachycardia. And a key finding for VTAC, if you weren't able to identify it just on the presence of the monomorphic wide complex tachycardia, is going to be the presence of AV dissociation. In other words, atrioventricular dissociation, where the P waves are going to appear completely independently of the QRS complexes. And that's because this rhythm is not sinus rhythm, right? It's originated elsewhere, so there's not going to be a QRS associated with each P wave. So we're seeing a great example of that here, where we're seeing the P waves with the red arrows that are occurring completely randomly, independently of the QRS complexes, and there's no association between the P waves and the QRS complexes. So now let's take a look at this EKG again and point out a few things that are very consistent with what we just learned. So first of all, we already mentioned that there was tachycardia here. The rate was maybe around 150 to 175. We talked about there not being a P wave before every QRS. So now we take a closer look now that we know that AV dissociation is a characteristic feature of VTAC, and we see some P waves here, right? There's one here, there's one here, there's certainly some here, there's certainly some that are buried within the QRS complexes, or that just, we see it right here kind of just on top of that QRS. So there's no dissociation or association between the P waves and the QRS complexes. So that feature is called AV dissociation. Right, we also see that this is wide complex QRS, very classically. And so these findings, and then we also see that the QRS complexes look similar. So these findings altogether are consistent with VTAC. So you should be able to recognize these features: the monomorphic aspect, the tachycardia, the fact that it's wide complex, and as an extra bonus, if you're able to identify the AV dissociation, that just confirms that this is VTAC. Certainly, you might not get a strip with AV dissociation, but even without that, in a patient with pre-existing structural heart disease who's presenting with a wide complex tachycardia, VTAC is going to be at the very top of your differential. And especially on the board's questions, this is commonly tested. So structural heart disease, pre-existing heart problems, MI, CAD, valvular problems, CHF, anything like that, a wide complex tachycardia that looks monomorphic, you should always be thinking VTAC. So this is a slam dunk, even without the presence of the AV dissociation. And if you see it, that's an added bonus. So let's review the management of VTAC very quickly. So as we mentioned already, stable patients, first line is going to be amiodarone. And second line, for patients who don't respond to amiodarone, we're going to use procainamide, sotalol, or lidocaine. But most of your questions are going to be um, identifying this first line agent. I've seen very few questions that ask you what the second line agent would be after giving amiodarone, if any. So it's good to know that if amiodarone has already been given, you could reach for one of these other agents, but first line amiodarone for stable VTAC. If patients are unstable, and the features that make a patient unstable for the purposes of these arrhythmias and ACLS algorithms is going to be the presence of hypotension, altered mentation, true respiratory distress, so not just a little bit of tachypnea and slightly labored breathing, but true signs of respiratory distress and the presence of ischemic chest pain. So unstable VTAC with pulses gets synchronized cardioversion, and unstable VTAC without pulses gets unsynchronized cardioversion, so defibrillation. So you should be able to identify VTAC in a question. You should be able to identify which of these three categories we're falling into in terms of management, and then identify what the first line management would be for each of these categories. So finally, just wrapping up these questions, we've already seen that answer choice G is going to be correct, synchronized cardioversion. And we've examined why, and we've learned a little bit about the high yield points for VTAC. So thanks so much for listening, and I will see you next time.